Good morning. I have the pleasure today to introduce you to Mr. David Willis. He will be our next speaker. And David actually has a very impressive background, and he's a national advisor in the healthcare industry. Healthcare is changing rapidly and will continue to do so within the next 18 months to 3 years. And his insight is greatly appreciated. David is Vice President of the Health Systems Strategy and Executive Education at the Advisory Board Company. And in this role, he works with the boards and executive teams of healthcare systems across the country to identify strategies for improving clinical performance, population health, revenue, profitability, as healthcare transitions from what is called the fee-for-service model to the value-based care delivery model. He's a featured speaker at the firm's annual meeting series for the CEOs, and he also oversees the firm's Health System Performance Initiative, in which he convenes working groups of senior executives at these healthcare systems to share insights and best practices in the areas of system integration, business and care model transformation, alignment, and physician engagement. During his tenure at the advisory board, David has held a variety of leadership roles, both as a senior faculty member and as a consultant in the firm's research and insights division. He's also served as a senior faculty member for their international division. He has an MBA from Yale University and holds a BS in mechanical engineering from Carnegie Mellon University. And he's originally from Boston, but currently resides in the Northern Virginia area, but remains a diehard Red Sox fan. So please help me give a warm welcome to Mr. David Willis.
Thank you. Very kind. So I'm 45 years old this year, and I'm pretty convinced that your introduction in seconds should always be less than your age in years. And what I think is interesting whenever I hear people read that is I guarantee you, 2 hours from now, the only thing that anybody will remember from that is the part about being the Red Sox fan. Right? And I bump into somebody at the airport later, they say, oh, you're with the guy from Boston. Right. That's it. So I throw that in there just so that there will be, in fact, something that you will remember about me when all is said and done. I'm very appreciative of the introduction, and I'm very appreciative of the chance to share with you some thoughts on what is going on in healthcare. And when I was invited to do this, this is a different audience than I usually speak with. Usually my audience is executives and senior medical staff professionals at some of the largest health systems in the country. When I began thinking about, okay, I know what I want to talk to you about, but how do I frame this in a way that I will hope will be interesting and helpful to you as I think about economic development? I absolutely, and I'm pleased to see Ms. Braun is in the audience, I love the quote that she put up at the end of her presentation, that change is inevitable, progress is optional. Right? And what we're going to see as we talk about healthcare is there is a lot of change. And frankly, that change is complicated. And to presume that I can put into what's going to end up being about a 45-minute presentation all of the change that is happening in healthcare would be a very naive presumption. What I hope to do is to give you a couple of important highlights that are driving change at a pace that the industry has never seen in the United States. And I believe that creates significant threats. Trust me, I talk to health systems all the time, and I hear a lot about the threats. It also creates significant opportunities. And if you are working in the field of economic development, I think one of the very interesting questions for a state like Wisconsin is, are we going to be a net importer or a net exporter of healthcare? And what does that mean? What does that mean for us? So I hope as we go through this that I'll be able to tease out some of the things that I think are important for you to be thinking about. I will try to leave some time at the end for questions, and if there's anything that I can answer, I'm happy to do that. Please let's be very clear as we go through this, because I will be talking a little bit about, say, changes due to healthcare reform. My employer, the Advisory Board Company, although we're located in Washington, D.C., is not in any way a government agency. We're a private company. We're actually publicly traded. You can look at the advisory board online and so forth. I'm going to give you the perspective that we have from researching these issues as we try to share ideas and best practices with hospitals. Before I get into the detail of healthcare, because it is complicated, and if you don't live in this world, you can very quickly drown in a sea of acronyms and terms that are incredibly complicated. Let me give you an analogy that I'm going to refer back to a couple of times that I think illustrates very well what is happening in healthcare today. When I got in last night after dinner, I went back to my hotel room, and I really wasn't ready for bed yet, so I popped open my laptop. I don't know if any of you are fans of the BBC series Sherlock. If my phone rings, that's the ringtone that I have, too, so just to give you an idea. And I watched an episode. Okay? Now, it's 2015. That's completely innocuous, right? There is nothing special about what I just described. That little thing that I did last night is reshaping and in some ways destroying the cable and satellite entertainment industry, for reasons that you in the room can probably understand very well. It is what economists or business school students would call channel disruption. The way that I and the way that most of you access our entertainment choices now is fundamentally different than it used to be. All right, again, I'm 45. When I was a kid, 1970s, coming home from school, and I wanted to watch cartoons on television, what choices did I have? Right. Right, I basically had 4 channels, right? You know, ABC, CBS, NBC, PBS, or you remember this, you could get up, walk across to the television, turn that knob from VHF to UHF, right? Dial up to like channel 44, and through static you could get something else, okay? That was the choice, right? My kids don't understand this, but that was the choice set that we had 35 years ago. Then the 1980s come along, we get cable, right? All of a sudden, now there's 100 choices. All kinds of things. Then broadband internet, right? So you get satellite packages. Now there's thousands of choices. Home shopping network and home shopping network if all you want to do is buy Hummel figurines, right? You've got international programming, foreign language programming, right? More choice than you could ever possibly imagine. And yet what have we learned with the advent of high-speed internet to the home and services like Netflix and Hulu and Amazon Prime? We've learned that actually people don't want broad choices. They want good choices. I want to watch what I want to watch. I want to get to what I want to see, and I don't want to pay for all that other stuff. Well, that's incredibly disruptive if you're Comcast, right, or if you're DirecTV, and your whole business model is based on getting people to pay for a whole lot of stuff, even though they're only going to watch and consume a small amount of it. That idea of channel disruption, of fundamentally reshaping how we get access to entertainment, is very analogous to what is going on in healthcare today. So as I talk through what is going to be some fairly complicated sounding things, I'm going to try to connect it back to, and this is how channel disruption is changing that picture. And this is why a lot of the things that are going on are creating real business and economic challenges for traditional healthcare providers. Does that make sense? Okay, so let me take you in, and I'm going to start right off with some of the wonky stuff, okay? 3 parts to my presentation. I want to describe what I'm going to call the coming retail revolution. And what I mean by that, when I say retail, I don't mean retail pharmacies necessarily, although that's a part of the picture. What I mean is a fundamental change in the way people get access to healthcare, which is really moving from what has been historically a wholesale model. You sell a small number of insurance products to a small number of employers, and then you get access to thousands or millions of patients through those channels, to a retail model where people are increasingly going to be buying their own insurance coverage through some flavor or another. That is a channel disruption activity that is fundamentally reshaping the industry. I want to share with you a little bit in my second section, how is the market responding? What are some of the things that people are doing? Okay. I think, again, there are threats and opportunities here, and I will close, time permitting, with a couple of comments on what might be the implications for economic development professionals. Okay? We in the right? This is not too late to switch if you want to go over to the other room. I actually think you're in the better room, so for what it's worth, we'll go with that. Very, very ugly, complicated slide. This is, if you run a hospital, this is your world. Okay? Let me boil this down very, very simply. Here's the little secret of running a hospital or a health system in America today. You basically have 2 kinds of patients. You have patients that are paid for through public insurance programs, Medicare, Medicaid predominantly, and you have patients that are paid for through commercial insurance programs, Blue Cross, Aetna, United, Security Health Plan, other health plans that you are familiar with, right? If you are a hospital today, that business is split about 50-50. About half of what you do is paid for through the public insurance programs, and about half of what you do is paid for through the commercial programs. The public payers don't pay you enough to deliver the care that you provide. On average, for every $1 of care that you provide, they pay you 86 cents. Does that sound like a fun way to run a business? Okay, you're underwater for half of what you do by about 14%. You stay in business because the commercial insurers pay you more than what it costs you to deliver care. Okay? I'm oversimplifying a lot of stuff here, but this is as simple as I can make it, the economics of running a large health system today. 2 parts of my business, I make money on one half of it, and I use that to cross-subsidize the fact that I lose money on everything else. And that's been true for a very, very long time. The problem with what I have just described is every single part of that picture is changing, and it is changing in a way that is probably less attractive to me if I am running a health system. Every part of this picture is changing. So to start with, this part that has always been bleak, I'm not paid as much money as it costs me to deliver care by the public insurers. is getting even worse. This part that I have always relied on to cross-subsidize and help me make up for is changing. It's not going to be as attractive. And the other thing that's not obvious here, as I said historically, this has been about a 50-50 split. What's the number one thing that's happening to the demographics of this country? Older. So just put your mindset in 15 years from now, this is no longer a 50-50 split. This is something like a 40-60 or a 30-70 split. Right? So what used to sort of balance out, now all of a sudden this part is a much bigger piece of the whole pie. Everybody start to get how the math gets really, really complicated here. So a lot of things that are changing are making this picture that historically has been what has kept healthcare in this country afloat, all of a sudden not look the same. Right? Now, I don't know, how many of you had a chance to print out copies of this? I know that slides were made available, and I think they still are. I'm going to skip a whole lot of things because, frankly, it's boring, and I want to get to sort of the punchline. But there's a lot in the next couple of slides that sort of shows you what I just described. Okay? We are aging as a population very, very rapidly. You see different figures, but something like any given day in this country, between 7,000 and 10,000 baby boomers age into the Medicare program. That's like a tidal wave, right? Millions and millions of people across this decade and the next aging into the retirement program that pays for health care. I have a lot of, again, very boring data on the right that basically makes the point that I said before. This goes from a relatively even split between the public insurance programs and the private to one that starts to look more like 3/4, 1/4. One way to think about that is every hospital in this country is going to be a public hospital a decade from now. Public hospitals have historically been safety net health systems that take care of people who can't afford to pay for them, and they get a lot of public support to be able to do that. Well, that increasingly is what every hospital in the United States is going to look like. Right? So a lot of just, again, basic background data here. Medicare is also cutting what they pay us. So 5 years ago, the passage of the Affordable Care Act did a lot of things. I mean, that bill is voluminous, and we do not have time today to go into half of what is covered there. But at a fundamental level, here's what happened, right? The deal that was struck between the administration, Congress, and hospitals in this country is we're going to pay you even less than we have paid you historically through Medicare. But we're going to take the, let's just say, 40 million people in this country who don't currently have insurance and for whom you don't get anything. And we're going to find ways to cover them through some plan. Maybe Medicaid, maybe commercial insurance. So what we take away from you on the one hand, we're going to give back to you on the other. That was the theory, right? Remains to be seen how well that will actually end up working. But just put your eyes on for a second how much money was taken away from what hospitals would have been paid through Medicare. Hundreds of billions of dollars, right? So this picture that I showed you a couple slides back, you know, Medicare was paying us 86 cents on the dollar. That's going to be even less than it was before. At the same time that more and more of the patients who are coming into my hospital are paid for by that program. Again, I'm throwing a lot of detail at you, and this can get very wonky, but does everybody start to understand why this is a bleak picture? There are other things that are going on with Medicare, too. Not only are they paying hospitals less, but every dollar that they pay hospitals now comes with a set of carrots and sticks attached to it. So a dollar may not be a dollar from Medicare anymore. You might get 95 cents on the dollar depending on what's your infection rate compared to other hospitals in this country. What's your readmission rate? How likely is it that after you've cared for a patient, they have to come back for more health care within the next 30 days? What's your mortality rate? Do you do a better job keeping people alive when they've come in after having a heart attack or not? They're measuring all of that stuff. And if you are a hospital that does well on those metrics, you can actually get $1.05 rather than $1. If you're a hospital that does very poorly on those metrics, you could end up getting 95 cents rather than $1. Right? So it's not just that I'm paying you less, but more and more of that money comes with a carrot or a stick attached to it. That's somewhat what people talk about when they say that healthcare is moving to a value-based reimbursement system. You no longer get paid just for doing whatever it is that you're doing. Some of what you get paid is going to be tied to, well, are you valuable in the care that you are delivering? Are you delivering a higher value care experience to your patient than somebody else's? Folks get that? Does that make sense? Am I boring people to tears, or is this interesting? Do you know all this stuff? Because if I'm telling you a million things that you already know, I'm not shy, by the way. Raise your hand and say, Dave, we got that. Move on. All right, I'm happy to do it. So big part of what's going on here is Medicare is paying hospitals less, putting carrots and sticks attached to what they're paying hospitals at the same time as Medicare becomes a bigger and bigger and bigger part of what every hospital does. And I'm not even beginning to touch on some of the other ways that they're changing how they are paying hospitals. But the thing that I would ask you to keep in mind is a dollar is no longer a dollar for Medicare. A dollar now has risk attached to it. And you may or may not get all of those dollars, depending on how good you are at doing what you do if you are a hospital. How many in the room work in the healthcare industry? Okay. Is that a fair summation? If you feel that I have grossly oversimplified, tell me, we can go into more detail. But that is what's happening with Medicare. I don't want to spend a lot of time talking about Medicaid. Let me just say that the picture in Medicaid is very similar. There is less money in it, and for a variety of reasons, there is more risk attached to it if you are providing health care. So I'm going to skip a lot of the slides that go over that stuff. We can come back and talk about a little bit more of them if you want when we get to question and answers. Here's the more important part of how that picture that I showed you on my first slide is changing. I talked about how the public insurance part, which has never been all that attractive, is getting even less attractive. Well, the commercial insurance part was always the very attractive part, right? Again, that was what we said is how hospitals and health systems stayed afloat. That's changing radically. The single biggest thing that I would pay attention to you, if I were you, across the next 10 years, is how does the commercial employer-sponsored health insurance model in Wisconsin evolve? It is evolving very fast in some parts of the country, not quite as fast in others, but it is evolving three ways. Most of you in the room, I assume, get access to health care because you work for an organization that provides health insurance to you as part of your benefits package. That's how it's worked for a long, long time, right? And you know how that works. I don't know how many choices you have. Every year I have 3, and they're actually 1. It's United Healthcare is who my employer provides, and there are 3 flavors of that I can choose in any given year. And I pay some of that, and my employer pays some of that, and then when I get sick or my children get sick, we pay differing amounts depending on what's going on, right? That's the basic idea. Well, what's the problem with that if you're an employer in this country or in this state? What do we not like if we're employers about that model? What's happened to it over time? It's very expensive. And it goes up every year faster than almost anything else. Right? Healthcare inflation in this country over the past 20 years has gone up 8 to 10% a year. What's inflation like in the rest of the economy? 2%. Right? So this is a very expensive thing that I do already that is getting more and more expensive all the time. Right? It puts a lot of pressure on my business to stay competitive. Well, employers for a long time have thought about, gosh, do we have to get into this? Do we have to do this? Or are there other ways? Right now, they have more options if they don't want to do that than they've ever had before. They have 3 big options. One option is they can just stop doing it. Stop providing insurance to my employees altogether. And you heard a lot of this discussed after the Affordable Care Act was signed, right? That there was this small employer mandate. If you're an employer and you don't provide insurance, the government is going to penalize you $2,000 per. Well, it costs you a lot more than $2,000 to provide insurance, so if I'm a logical CFO, I'd rather pay the $2,000 than whatever it costs me to provide insurance. And right now, even that is on sale because the employer mandate is currently, not part of the picture. That's been delayed and might be delayed indefinitely. We might never have it. So there is a believable proposition to say, if I'm an economically rational company, I should just get out of this altogether. And I have an alternative now. It's not that I'm completely cutting my employees loose. They can go buy coverage on the exchanges. Right? They now have an alternative way to go in and buy health care. So there's one argument that says that some employers, some have already done this, but that a lot of employers will do that. They will just get out of this altogether. I call that the abdication model. Going to get out of health benefits altogether. Do you know who really hates that idea, by the way, on the left? The insurance industry and the insurance brokers hate that idea. Hate that idea. So the insurance brokers, people like Mercer and Aon Hewitt and Towers Watson of the world that sell insurance products to companies to provide for their employees, hate this idea because this is how I make money. I make money selling insurance, and if you're not doing that anymore, that's bad. So the insurance brokers are going to employers, and they're saying, wait a minute, there's another option that I have for you here. Don't cut your employees loose and send them to the public exchanges. Who knows what's going to happen with those? We're going to put together a customized private exchange of health plans for you. We will go out to the health plans where your employees are. We will work with them. We will put together a big menu of offerings that are with the providers that they want to get access to, right, covering the types of things that your employees are going to use. And we'll provide a private exchange and we'll manage it. And here's what we're going to do. You are going to turn health care into a 401k. Going to use another analogy here, right? Everybody remember about 20 years ago in this country, we moved massively from defined benefit retirement plans. You had a pension, and there was a guarantee that there was going to be money in there for you when you retired, to a defined contribution. Your employer no longer guarantees you that. You've got some money, they might put some in, you're going to put some in, and what happens to it at that point is up to you. Right? Everybody get that change? That's essentially what this middle option does, is it takes health care, and instead of me as the employer being on the hook for that going up 10% a year, I'm just going to give you a check, employee, and it's going to be for so much money, and next year I'll increase that by 2%, not 10%. And I'm going to give you that check, and you're going to go on to this private exchange that we've put together for you, and you're going to buy some insurance plan from it. And you can decide if you want to take the check that I've given you and you want to buy something more expensive, but that's going to come out of your pocket, or you can decide that you want to buy something that's less expensive. It's entirely up to you. And interestingly, I'm talking to a lot of employers that are doing this. Many of the employees like this. They feel that they get a lot more choice when they go to this model, right? Think of what I just described to you. I have 3 choices every year, and it's all from the same company. With a private exchange, I often have 10, 15 from different employers. And I can go in there and I can actually see which one of these has my child's pediatrician, which one of these has my primary care physician, my wife's OBGYN, right? I can go in and I can pick out the ones that have what I want and see, how much it's going to cost me to use them. So a lot of employees, certainly won't say all, but a lot of employees like this model. They certainly like this model better than this one. And then there's a third thing that some employers are doing, larger employers in particular, which is they're saying, I'm going to continue to provide a fairly traditional insurance benefit to my employees, but I'm going to get a lot more aggressive at going out to health systems and telling them what I want. Intel is doing this in most of their major markets. Boeing is doing this in most of their major markets. GE is doing this in a lot of their markets. Going out to an individual health system and say, you know what, I'm going to give everything to you. I'm basically going to send all of my employees to you, your hospitals, your doctors for care. But you're going to have to guarantee me some things. You're going to guarantee me that my costs are not going to go like this. They're going to go something like that. And if you can't deliver that, guess what? You're going to pay me back some of that money. You're also going to guarantee me that if my employee wants to get in to see a doctor, that they can get in to see a doctor. You're going to guarantee me that you will meet things like same-day primary care appointments, right? Short wait times to see a specialist. So some employers are going to take the option of, I'm going to continue to do this, but I'm going to treat this more aggressively, the way that I buy every other good or service. I am going to demand a higher standard of performance from the person who's providing it to me. Does that make sense to folks? 3 big options that employers have now that are changing. This is where we're going to start to see the channel disruption, because all of these are very, very, very different from what employers do today. I've got some more details in here on what's going on with the public and the private exchanges. Believe it or not, you remember about a year ago at this time, we had the first wave of the Affordable Care Act exchanges, and it was a disaster from the word go. They couldn't get the website to work. Nobody was signing up. Well, interestingly, what happened, by the time we got to the end of the open enrollment period, they'd actually exceeded their year 1 goal. The exchanges actually did what the administration hoped they would do in year 1. Now, we'll see what happens with year 2, right? We're approaching the end of open enrollment period, what happens there. So interestingly enough, this does start to look like a viable market. Got a question for you. When people bought insurance coverage on the exchanges, and many of these were people who had never bought insurance coverage themselves before, when they did this last year, what did they buy? What kinds of things did they buy? Do you know? Any of you do it? Any of you buy coverage through an exchange? I will tell you what they buy. They tend to buy the cheapest thing that they can afford from the standpoint of the health insurance premium. I go on there, there's a whole bunch of different plans at different tiers, and they've got different insurance premiums, how much it's going to cost me per month to buy this. They tended to buy things that were at the very bottom of that price list. Well, those products have 2 things that are typically true of them. One is they are typically very limited in the number of doctors and hospitals that are in them. Right? They often have what's called a narrow network of healthcare providers that you can access. Many people didn't realize how narrow the network was when they bought it, so it'll be interesting to see what, if anything, changes this year. The other thing that tends to happen is those very cheap premium insurance plans come with a very high deductible. This is a very smart room, right? I don't know that I need to explain deductibles, right? You get this. Often a $5,000 or higher deductible. People have never had to deal with that before. We raised a generation of Americans to think that health care costs $25. Because when you went in to see a doctor, that's what you paid. When you went into the hospital, maybe you paid $50 or $100, but you did not pay what it costs to deliver the care. With a $5,000 deductible, you are self-insured. For anything outside of a hospitalization, you are self-insured. You are paying the entirety of that medical bill out of your own pocket. And guess what people discovered over the past year? Healthcare is more expensive than we knew. We are turning a generation of Americans who have no idea what healthcare costs into people who are now going to carry a whole lot of that burden. And they are learning in a hurry what healthcare costs. And they start to behave very much like they behave when they buy any other good and service when they're paying their own money out of their own pocket. They start asking questions like, how much does this cost me? Guess what most hospitals can't answer for them? Right? So problem number one, think about this for a second. What other industry is this true? We can't tell our customer what it's going to cost them. Problem number one, right? We're turning people loose. We're going to ask them to pay all this money, and they don't know, right? Even if they call us to ask us, they don't know what it's going to cost them. Problem number two, what else do people do when faced with a really expensive potential medical bill? Cut back, put it off. My knee hurts, not that bad. Okay? I'm going to deal with this and hope it gets better over the weekend, right? Okay, so that's what's going to happen. We're going to delay or we're going to defer care. The other thing that happens is they go and they get health care. They just don't pay you for it. Now you have to get in the collections business, and that's fun. Right? Nobody who works in healthcare in this country got into healthcare because they liked being in the collections business. So there's a whole lot of things that happen when people all of a sudden are facing a very high deductible. That not only happens on the public exchanges, which is what I've been talking about, that happens on the private exchanges. Right? Those ones that I said the brokers are coming and working with employers and saying we're going to put together a customized network. People behave exactly the same way when they buy insurance through that model as they do when they buy insurance on the public exchanges. They buy cheap premiums, high deductibles, high out-of-pocket cost exposure to me, and I start to act very differently when I'm accessing health care. The reason that this is a big deal is because that market of how many people are going to buy their own insurance coverage through the exchanges is growing very, very fast. The federal government believes that by the time we get to 2018, 25 million people or thereabouts will buy insurance through the public exchanges. The private exchanges, very fast growing, still small today, but paper by Accenture says that's going to be 40 million people by 2018. Paper by Deloitte says that's going to be 60 million people by 2018. I don't know how good any of these companies' crystal balls are.
Put those numbers in context. 25 million is what percent of the total need?
So there's, 350 million people in the country today, right? So 25 million people is still relatively small compared to how many who were uninsured, which was about 40 million at the start of this, right? So that's where a lot of that, not all of that, is coming from.
How does Medicare fit into that?
How does Medicare fit into what exactly?
Well, your numbers. In other words,
So Medicare, we're not talking about Medicare right now. Now I'm talking about what is.
so when you say 325 million, that includes Medicare recipients.
Yeah, 325 million. If we go back, I think I showed some of these numbers early on. You know, Medicare is going to be 65 million people of those by the time we get there, right? Okay. So the really important point to understand about what is going on with the exchanges is, let's just take the more conservative of the number that's been published, the Accenture estimate of 40 million people. That's 40 million people who right now, for the most part, are getting fairly robust insurance through their employer, moving into a model where they are going to have less robust insurance, where they are on the hook for a lot more of the actual cost of health care. We have no history in this country to estimate or to model what happens if 40 million people are walking around carrying a $5,000 deductible. We can make some guesses based on what we're seeing from the first year or two of this experiment. But I think what's happening is channel disruption. What we have going on here is people accessing the healthcare system in a very different way than they have before, buying a different kind of insurance product, and therefore acting very differently when it comes time to make a decision about how and where and when I am going to get health care itself. That channel disruption is going to be a very big deal. I don't know exactly what the numbers will end up looking like. I don't have the crystal ball either. But before you think that, that's just a pie in the sky thing and it might not happen, I would argue with you that the big investment banks and retirement brokerage houses thought that this might not happen to them 25 years ago too. Remember we talked about the defined benefit to defined contribution, the pension to 401k move? Two thought exercises to ask yourself and any of your colleagues. Do you know any organization who went the other direction? Who went from a 401k to a pension? I don't. Do you know any organization that went from a pension to a 401k and then went back? I don't. My guess is this is a one-way street. I don't know how steep it is, so I don't know how fast this is going to happen. Right? In the financial services industry, it basically took place across 15 years. I could give you an argument that it's going to be a lot faster than that in healthcare. But I think this is a one-way street. I think we are going down the path of more financial accountability and more risk to the consumer. And I doubt that that is going to change. We could debate the details as to how quickly that's going to happen. But we have some experience to suggest that once the business industry decides that it wants to move in this direction, it's just going to keep moving in this direction. Big thing that I would be watching is what are employers in Wisconsin doing? I would be paying attention to this because that's going to give you an indicator on which of those different potential paths the state is going to go down. It's probably going to be all of them, but in what combination and how quickly. I would be watching those details very, very, very carefully. I'm going to skip some of the other things that are going on out here and just make the argument for you that the world that I have just described starts to look like a retail market. Individuals who are price sensitive because they are spending their own money. I'm just walking down the right-hand side of this slide. Much narrower networks around which I'm going to access health care. I can change plans a lot easier. If you work for an employer today and you don't like your health insurance coverage, what can you do about it? Wait for open enrollment, but you're going to have the same choices next year as you had this year. Again, I have 3 flavors of the same ice cream that I can choose. If I don't happen to like that, I can lobby my employer, I suppose, to change it, but how often does that work? And in the exchange-traded model, you don't like the plan that you're on, you can change to a completely different plan the next year, completely different provider the next year. This starts to sound a lot more to me like the markets for other goods and services in this country, right? Low switching costs. If I don't like my service provider, I can change to another one. I am on the hook for what it costs. I have to start judging the quality and value trade-offs of one organization to another. Now, here's the thing that I think is interesting. I don't think as people we're very good at doing that in healthcare. We're not good at assessing our own risk. How likely am I to need an expensive hospitalization? We're not good at figuring out, is Dr. A better than Dr. B? Is hospital A better than hospital B? We have very vague notions of that based on branding and reputation. We're not very good yet as consumers at making those decisions, just like we were terrible at making decisions about our own retirement when we were turned loose into that world. Whole lot of data across 20 years that says, as Americans, how did we do when we were made responsible for our own retirement? Not very well. We didn't know the first thing about diversification of the portfolio. We underinvested. We put less money away than we should have, right? You've all seen data like this over time. And yet that train kept moving, didn't it? Even though quite arguably it was not in the best interest of individual Americans for that change to happen. I think this might continue to happen even if it's not obvious that this is a good thing for patients, at least initially. So here's a quick question for economic development. Because a lot of what is happening right now is service providers jumping into an immature marketplace and trying to say, how do we make it more mature? How do we make this function like a real market? How do we give people tools to better make decisions about how they buy health care? How do we give people tools to better understand how to trade off the quality of one provider versus another? We just said hospitals can't tell you how much something costs. How do we give individuals and hospitals tools so that they can answer that question? There are massive market imperfections right now in the world that I have just described, and therefore very, very big opportunities for who can solve it. Let me give just a couple of examples of how the market is responding. I said we're going to be very price sensitive because with a $5,000 deductible, we're self-insured for anything other than going into the hospital. We went out this past year, because my company is located in D.C., and we asked a whole bunch of different providers of imaging services what it costs if you go in to get an MRI on your lower back. Show you some of the data up there on the right. I'm going to offend somebody who works in healthcare in the audience. This is not exactly a commodity service. This is fairly close to a commodity service. An MRI, lower back without contrast, is pretty similar no matter where you get it. There are some variations. You could go to one place and pay $400 for that. You could go to another place and pay $2,100 for that. I don't know what that picture is going to look like in 5 years, but it's not going to look like that. I don't know that it's all going to be $400, but you're not going to have a disparity of 5x for something that is pretty close to a commodity service. This is not like buying a Kia versus a BMW. All right, that's not the kind of distinction that we're talking about here. It's going to look a lot more like 400. Maybe this 2100, which is a big academic medical center, maybe they're going to get away with charging $600, but they're going to have to justify that. They're going to have to convince me somehow as a consumer, because I'm paying every one of those dollars out of my own pocket, why I should pay extra money to come to you. If you're paying attention, if you're taking notes, something that you might want to write down, do you know where most hospitals today make a lot of their money? On this stuff. And I just described you a world in which the price is going to collapse. Every hospital has a different income statement. But if I went out and looked at a lot of hospitals, they make money on outpatient imaging, elective surgery, outpatient surgery. They make money predominantly on the stuff that is going to fall within the patient's deductible, where the patient's price sensitivity is going to be incredibly significant and price pressure is going to come down. Remember, we said at the very, very beginning, the first slide that I put up there, hospitals in America stay open today because they cross-subsidize money losing on the public payer side with more lucrative reimbursement on the commercially insured patient side. Think about what this is doing to that good side of that picture. Pushing price rapidly down in the area of my business that I always use to make up for the fact that I lose money everywhere else. Do we start to see how the channel disruption is going to fundamentally reshape the economics of this industry? Again, I'm oversimplifying a lot of things here, but I want to give you a picture as to what is happening. So what else is happening in this world? A company called Castlight, and I'm not endorsing them, I'm just showing them up there as an example. You might want to look these folks up. They have a very simple, not very sophisticated app that employers buy for their employees. Castlight sells a product to my employer buys it, gives it to the employees. I've got this thing on my app now. My doctor wants me to go get that MRI. I pull this thing up, and it tells me, for my benefits plan, how much will it cost me to get that MRI at point A or point B? And all of a sudden, that data that I just showed you on the previous page is sitting right here. And I'm having the conversation with my doctor. Gosh, you wanted me to go to big academic center imaging to get this done. It's going to cost me $2,100. Can't I go to Smith Imaging around the corner and pay $400 for that? That conversation's starting to happen now. Castlight, one of a suite of tools that is empowering consumers to ask that question, get that answer, and begin to say, under what circumstances would I make that trade? When would I go and get the more expensive one? Again, this is not a very good one. Here's the thing about Castlight. They went public this past year, and on the day of their IPO, the stock went up 150%. The tool is not very good. I guarantee you every entrepreneur in Silicon Valley, the day of that IPO, woke up and said, oh, price transparency in healthcare. I can get my developers working on that. We can beat this Castlight thing. This is going to become something that we will all have. We will all have versions of this in one fashion or another that will begin to give us tools to understand what healthcare is going to cost. Another company called CarePilot. I like to use these analogies. This is kind of a StubHub. Okay, you're familiar with StubHub, that model? You can pay different prices for tickets and demand higher events rather than you can pay more. What CarePilot does is work with providers, health systems, physician groups, to say, gosh, that CT scan that you have, nobody ever comes in at 11 o'clock on Tuesdays to get the CT scan. They all want to come in at 4 o'clock on Friday afternoon. Well, guess what you can start to do? You can price differentially. You got that big machine sitting empty there on Tuesday at 11 o'clock? Cut the price in half. Now the patient can choose. All right, if I really want to go at Friday at 4 o'clock, I'm going to wait a little bit longer and I'm going to pay more for it. If I'm willing to take off work at 11 o'clock on Tuesday morning and go in and get it done, I can pay less money. This is not rocket science in any other industry. We do this, right? But this kind of price differentiation is going to come to healthcare. Here's a surgery center in Oklahoma run by a group of doctors posting prices online. My goodness, you've never seen this in healthcare before. Surgery, price, online. You're a patient here, you go in, you see exactly what that thing is going to cost you. Here's a really interesting one, Walmart. How are we doing on time, by the way?
It's 12 after.
Thank you. Walmart. Like Walgreens, like CVS, like many others, is getting into the in-store clinic business. Walmart, for reasons we could speculate, I'm not going to go into because I don't know 100% why they're doing this. But Walmart looks at everything that I've just described, and while it's terrifying if I'm a big health system, Walmart says, oh, this is a gravy train. We're about to have millions of people in this country who are going to be paying out of pocket for health care and aren't going to want to pay big health system prices for these things. We can start to do some of that stuff. They are trying right now, have rolled out in a number of stores in Texas and in South Carolina, and if it works, their plan is to go nationwide with this, a model where they are going to put a nurse and a pharmacist in the store. Probably not a doctor. That's too expensive. We're going to put a nurse and a pharmacist in the store, and we're going to do as much primary care as their capabilities and the regulations in each state will allow. Primary care visit in this country, depending on where you are, will cost you between $90 and $150 if you're paying for it out of pocket. Walmart is testing two different prices. If you're a Walmart employee, 1.3 million of them in the country, by the way, that visit costs you $4. That's not a typo. That's also not a copay. That's the price. If I'm a Walmart employee, I can go in and I can get a primary care visit from that nurse and that pharmacist for $4. If I'm a Walmart customer, $40. $40, 90 to 150. That's big advantage number one. They think they can price this service in a way that will be utterly disruptive to traditional providers of healthcare. What's advantage number two that Walmart's going to have here? When do you think they're open? So, yeah, let's come back to that point in a second. So, big thing number two, they're not doing 24/7 yet, although one could easily imagine they'll do that. Right now, the model that they're testing is 15 hours a day, 7 days a week. So now, I don't know what it's like where you are, and I think Wisconsin does this better than a lot of places, but let me tell you what it's like when I want to see my doctor, my primary care physician in D.C. If I call him at 1 o'clock in the afternoon during the week, I get a voicemail recording. And that voicemail recording says, "We're closed for lunch, please call back." What kind of customer-facing business in the 21st century asks the customer to call back? They're not really closed for lunch. Do you know what he's doing? He's catching up. He's catching up. All right, my doctor is not lazy. He is working hard because everything that he did that morning has put him behind. Right, he's catching up. That's actually what's going on here. And I didn't even want to see him that day. I just wanted to call him to make an appointment to come in to see him sometime sooner. Right? But now suppose I'm that individual and I have to trade. It's not just $40 at Walmart versus 90 to 150. It's I can go in on my way home. I can go in and stop off while I'm picking up groceries, whatever I'm going to get for my kids, go in and see somebody get this taken care of, or I can wait 3 days, 5 days, a week, you tell me, and pay 2 to 3 times that to go and see my doctor. So Walmart looks at this, they look at this channel disruption, and they say, I mean, they're almost licking their chops, right? I can price this at a way that's going to be very disruptive to you. I can put an access model in place. When I say access model, that sounds wonky, but you know what I mean. How easy it is to get in and see somebody that's going to be very disruptive to you as a traditional provider. And then, while you're there, they're going to hope to do some other things. If there's a prescription that needs to be had, they want to sell you that. They're very good at store design. They have figured out what products to put in proximity to the clinic so that you'll be likely to buy something. Right? I have no idea if this is going to be any good. I could make a public policy argument to you that says this is not a terribly good idea for the country. You know what I think we cannot do? Is put our head in the sands and assume that they're not going to do it. This is a big threat if you are a health system or a traditional primary care physician that we're going to have to figure out. Are we going to have to match them on price? Are we going to have to be comparable to them on price? Are we going to have an access model that lets people see a doctor when they want to see a doctor and not wait for when it's convenient for us? These are very, very hard decisions that hospitals and health systems are having to make. Walgreens wants to go a little bit further. They're making a big investment in a company called Theranos. My Greek's not great. If I've mispronounced that, forgive me. Theranos is a lab company. How many of you have kids and have had to ever take them to get their blood drawn? Is that a fun experience for you? That's an awful experience. Both of my children have regular reasons to get their blood drawn. That is a terrible experience. You go in, you sit at a facility, you wait a whole lot of time. It never looks like it's all that clean to me. The phlebotomist is competent, I guess, but not friendly. And half the time they're missing the veins, right? It's not a fun experience at all. Theranos is a technology that with a finger prick, so a tiny drop of blood, not a vial that is taken out of your arm, a tiny drop of blood will do most of the tests that a lab will do today, for a fraction of the cost. So Walgreens doesn't want to stop at putting a clinic in the store and doing some primary care for you. You need your blood drawn, we want to do that right here for you too. And oh my goodness, the finger prick. Look, Johnny didn't even cry. Right? No waiting time. We took care of that right there. It cost you a couple of bucks rather than what it's going to pay you at the lab. They're going to start to reshape customer expectations, not only for what primary care services should be like, but for what lab services should be like. Right? Again, if you're economic development, be thinking about this. This market that I have just described to you creates opportunities. It creates opportunities for people who can solve the price transparency problem, who can deliver a lower cost service, who can deliver a better service experience, a better access model than what patients are used to. Very, very disruptive, huge opportunity for who can solve it. I have other things that are going on here. I'm going to skip them. Let's just go to, I guess, my closing thoughts. I have 3 questions that I would turn to you that I would be thinking about, and there's a million more that we could ask. One that I think is very important is I've described a possible future to you that starts to look like a retail market for healthcare. How quickly, if that happens, does it happen in the state of Wisconsin? I don't think you're there yet, but there are some things that are already pushing you in that direction. How quickly does that evolve? I would be watching that. One of the indicators that I suggested you watch is what decisions are employers in Wisconsin making about their insurance. I said there's 3 different paths they could go down. Be paying attention to who's doing what with their employees. Second one, and we've only touched on this, the geographic scope of competition for healthcare is much broader than it ever has been before. A couple of reasons for that. One is when people are spending a lot of their own money, they start to think about, would I drive 10 minutes further to save $100, $200? Maybe, right? Maybe not in Wisconsin in January. Maybe I want to go to the closest place possible, right? But in a lot of places, I will drive maybe significantly farther to save a significant amount of money. A lot of stuff can be done over the internet now that used to require an in-person touch. Right? I have a colleague that I work with who does most of his physician consultations now via his iPad and FaceTime. The practice that he sees is in D.C., but they have colleagues that have an office in San Francisco. And if the doctor in D.C. can't see him, they will do a FaceTime consultation with a doctor in the San Francisco office. And for a whole lot of primary care, that is actually perfectly fine. Right? More and more technology will be available that will let us deliver healthcare through greater distances than we have ever had to before. A lot of what right now requires a face-to-face visit with a physician will not require a face-to-face visit and may not require a physician. The geographic scope of competition is going to be much vaster. A question that I have for you is, will the state of Wisconsin be a net importer or exporter of that? Will people who are here access healthcare somewhere else, or will you deliver healthcare to people who are currently somewhere else? Huge economic opportunity if we get that right. And then the third one, and I've mentioned this a lot, all the market inefficiencies right now. We have a nascent, immature market for the types of things that I've been talking about. Big, big opportunities for things like solving the price transparency problem. How do we help patients make cost-effective decisions about where they go and get their health care? Because they're not prepared to do that right now. What are the products, the services, the goods, the industries that will be created across the next 10 years to help to solve that problem? Big, big, booming opportunity if we can be part of the solution to that. Folks, I hope you found some of that interesting. That is the world of change in healthcare as I see it. I boiled it down to what I think are some of the most critical points. I oversimplified a lot of things, but I would be happy to take thoughts or questions or comments from any of you. Please.
One of the discussions I've been part of with some folks is that we're going from a kind of regular health model to retail model, that the purpose of the Affordable Care Act is in fact to go beyond, that the retail model is going to cause so much anxiety that people will simply want government to take over health care. Are you seeing that?
I have absolutely no ability to predict what could happen on the political landscape. And it's really, really dangerous when you live and work in Washington, D.C. to try to play that game. And so I will not. Here's what I think is the interesting thing, though, is just think about how the world that I have just described to you is, in fact, very, very, very different from a government takeover of the healthcare system, right? The conversation over the past couple of years has been about this is a government takeover of the healthcare system. But when you look at how it is manifesting in practice, it actually looks a whole lot more market-oriented than we've ever actually had before. Now, I don't know what will happen as over time people start to say, you know, thought I knew what I was doing, turns out I didn't, not so happy about this picture, right? I don't know. But part of what I wanted to share with you today is employers are going to have a very, very big say in what the outcome of that is. And, you know, they're acting in ways that I think are not terribly unpredictable given the choices that are available to them. So I apologize. I'm not directly answering your question because I can't, but I shared just some thoughts. So a lot of hands up here. I'm just going to kind of do this, okay? So you, ma'am, in the next row, and then I'll keep going back and I'll win my way across.
Kind of along that line, but, you know, there's some similarities in this, what Medicare does and the government regulation piece is by mandating and regulating, you know, how reimbursements are done and that's how they take over. So, I mean, in the Medicare industry, they just are putting new restrictions on how much drug companies get reimbursed for drugs. And I hate to admit it, but I just went through my how to sign up for Medicare class. And so what you're saying, there's a lot of there's a lot of similarities that I'm picking up on. But I take a tier 3 drug, and the full price of that drug, they ran the analysis, varies from $28 to $200 based on the pharmacy that I pick. And they're all available in the area. So that's the kind of thing, and then government comes in and regulates. But the other thing that I found on your MRI example, I just sat through another presentation, and, you know, they made the comment that healthcare is the only industry where the customer will pay the highest price to get the best and the latest technology. So now maybe that $2,300 MRI is that costly because it's the best and the latest and the quickest and the fastest machine versus the $400 MRI.
So it may be, but here's my challenge every time I hear that. Has the customer been paying that price?
No.
In most cases historically in the country, the customer has not been the one paying that price.
Not the customer. I mean, we are indirectly. We are the customer paying that because they're charging.
Yeah. So, this is an interesting thing. You know, healthcare is in some ways a credence good, and what I mean by that, what economists would mean by that, is higher price can be used to signal higher quality, and that's a very good theoretical argument until you've actually put, you know, a family making $40,000 a year with a $5,000 deductible in the hands of having to make that choice. And even if they're not all that sophisticated, if they ask just a couple of questions, they're very quickly going to realize that there is no economic justification for the difference in price between $2,100 and $400. There might be a small justification. One of the things that's interesting, it is exactly the same group of radiologists who will read the results of that test at those two facilities. Exactly the same group of doctors doing this. So the academic medical center can't even make the argument that, you know, we have a better faculty in radiology on this. It's actually exactly the same group of doctors. And, you know, it's funny, once you start peeling the onion on that, one of the things that we learn in healthcare is there may be reasons why service A is priced higher than service B, but there's not a lot of rationality behind how things are priced in healthcare. And what we're doing is now we're seeing what happens. What happens when you shine the light of day on that and make the individual patient accountable for the difference? Big experiment that I would argue is going on nationally right now. We will see. How much more will people pay? How much longer will they wait in order to get care from entity A versus entity B? Yes, please.
So my experience with that is there are sometimes when you need a specific test, but to get to that, they make you take 1 or 2 tests before it, even though you know you need test C. But according to their insurance requirements, you have to take these other tests in advance. It's like, let's go. I don't need A and B, I need C. And they're like, well, the insurance protocols won't allow us to get to C unless we do A and B. It's like, well, I have this test every year, and we always get to C because you know you need that one, so can't you just write in somebody can actually just skip the other two components of expense and get to the one where it's a documented, they already know.
Very, very interesting set of questions, right? In a high deductible world, does the insurance company have less incentive to sort of play gatekeeper on things like that? That's a very interesting question, right?
The 86% didn't answer that.
Big experiment that we have going on right now. Yep.
The statistic you quoted about 86 cents is the Medicare reimbursement on the dollar for that portion of the population. We've known that historically in Wisconsin, because of the way that the formulas are set up, our reimbursement is actually much lower than that. Is that being fixed as part of the move towards the outcome-based performance, or is that becoming more equitable across the country?
So there are a lot of different ways in which the Medicare payment model is changing. But there will continue to be these things that are not equal based on cost of living adjustments and other things that factor into Medicare. The big takeaway that everybody should have is wherever you are on that scale right now, you're going to be here. Right? Whether or not we slightly balance them out a little bit, we may. For example, one of the other things that differentiates is some health systems get paid more because of the amount of medical education that they provide. Well, some of that is being taken away. So where some hospital gets a little bit of a higher bump than others, that's going to equilibrate a little bit. So I am not an expert in all the nuances of Medicare economics, but yeah, some of that. Back in the back row, sir.
I guess one of my biggest questions is, I definitely see the movement. I see everything what you're saying, but what is the Doctors Association and the medical industry? What are the conversations in there? I can see a lot of very old school doctors saying, I will never change my ways, and I can see a lot of new ones coming in, understanding what's going on. I just kind of see the healthcare industry as being maybe one of the biggest hurdles to this change until Walmart or CVS or Walgreens fully roll out their models.
No doubt, sir. And I think, it is an oversimplification, but not a terribly inaccurate one to say that, if I'm speaking to a room of doctors, I can almost plot them by age on a curve that will predict their reaction to anything that I am talking about here, right? So there are a whole lot of doctors who are sort of making the calculation, how much do I have in my retirement? Can I just do it the way that I've done it for 3 more years and then hang up, right? And I'm done. And there's a lot of folks who are coming out now who have a very, very different proposition, right? There are many younger doctors are going to work for a salary, being employed by a health system rather than being an independent doctor who sort of has to be entrepreneurial and make his own practice. There's a different work-life balance trade-off that they want from their career than many of their older colleagues do. So there is, I think, a lot going on within the medical community that is going to have a say in this. But I think one of the things that we should not assume is that we're going to be able to reverse the trend towards greater patient accountability. And I think that's almost a guarantee to happen. And it's very interesting to me because when I first started talking about the Affordable Care Act 5 years ago, one of the things that is used in that legislation is the term Accountable Care Organization, ACO, which is an organization that agrees to have some of their payment tied to some of the quality of the care that they provide. Okay? I'm oversimplifying dramatically, but an accountable care organization has some of their payment tied to the quality of the care they provide. And a very common thing that I heard when I talked about this would be, a physician who would say, okay, fine to hold me and my colleagues accountable. When do we hold the patient accountable? When do we hold the patient accountable who's not quitting smoking, who's not doing what I tell them to do, who's not changing their lifestyle, not taking their medications, not following through on their diet and exercise plan? Well, the world that I've kind of described to you today is one in which the patient actually is a lot accountable for that. A lot. So I don't think we're going to change that trend. We could argue about the pace of it, but I think it's going to continue to happen. Yes, sir.
Picking up on the accountability, and also, first I want to tell you that this is a lucid presentation, in my opinion, you did.
Well, thank you.
I want to come back as a healthcare economist as part of one school-based.
I take that to be high praise. Thank you very much.
But I will tell you that I was disappointed in one part, and that's the orphan child of the healthcare system was not addressed, and that's prevention. And my theory, tell me what you think, is that we are forced into making more retail choices as consumers, that we may demand some of the prevention services that are not currently covered under most healthcare plans. Do you see that as a possibility? And by the way, in the interest of full disclosure, my wife owns a health food store, and I'm a sort of silent partner.
Yep. So, wonderful question. The role of preventive care here, I think, happens twofold. So one is, let me sort of give you the downside risk. The downside risk is I'm the patient, I'm now paying for everything out of pocket. I start skipping stuff that I shouldn't be skipping. And I don't get that symptom look like, and now it's full-blown influenza, and I'm ending up in the hospital when if we had attacked this a little bit more aggressively. Or I've got a sore throat, it's been persistent, I keep going down to the Minute Clinic or whatever for a throat swab, they tell me I don't have strep. What they missed is that it's actually early-stage throat cancer. And had I gone in and seen a doctor, I might have caught that, right? So there is a huge risk here. And I'm 100% confident that as individuals in this country, we will make bad decisions about how we access what kinds of preventive care, and we will pay a price for that. There is a countervailing set of things, though, that are happening. So a lot of those value-based payment programs that I just touched on at the beginning, many of them now put a very stark incentive in place for the doctor or the hospital group to be much more aggressive at making sure that that stuff gets done. So, for example, one of the programs that Medicare is doing right now will basically reward a hospital if their chronically ill patients don't need to be in the hospital as much. Well, now all of a sudden, I have a very intense interest in making sure that Mrs. Smith is taking the medication for her heart failure and is weighing herself every day. And I might put her on a telephonic protocol. So I might put a little GPS on her scale. Mrs. Smith, step on that thing, and if I don't get an upload from your scale in the morning, I'm going to have the nurse call you. We might come out and take a look at you. Right? So there are some forces that I think are going to push very hard towards greater provider-driven emphasis on preventative care, at the same time that patients might have an economic incentive not to want to do as much. I can't tell you where I think the balance of those two things are going to come out, but you're right to raise it. The role of preventive care here is very, very important, and there are forces butting each way. I think we have time for one more. Is that fair? Are we good? Okay, please.
I'm very concerned about rural areas. My area is rural. We have issues with broadband. You just mentioned about uploading.
Yep.
A lot of rural hospitals. I'm concerned.
I would be too. Okay. Another one of the predictions that I feel fairly safe making, and I'm not going to give you a hard number, there will be fewer hospitals in the country in 10 years than there are today.
I guess related to that, is there something we should be doing as economic developers to convening?
So let me boil the entirety of my presentation down to one thing for economic development: cost-effective access to care. How do we make sure that the people in this state have it? And what are the business opportunities that are available to provide it? So do we need to make sure that we have broadband internet to all of those communities? And how do we get that financed? Do we need to have roving medical vans? Norton Healthcare in Louisville does this, by the way. They've got a van that they take out to some of those remote places to make sure that people have access to. GE Healthcare is testing in rural India, an ultrasound device that is about this big, that they can train a nurse to go out into the poorest areas of India and help a high-risk pregnancy, not go wrong. Should we have that technology available at every public library in the country, right, so that you could have somebody come in on a regular basis and work with pregnant women who don't have the ability to access a high-risk OBGYN care center, that type of thing. Cost-effective access to care, I think, is where a lot of this game is going to be won or lost, and where some of the possibly negative outcomes that we've talked about can be prevented or exacerbated. I worry a lot about the rural areas, too. I think we're going to have fewer of the hospitals that are targeted to serve them. Those will probably end up being more like ambulatory care centers, emergency departments, but they probably won't continue to exist in the way that they have today. I think that's a fairly safe assumption.
There's going to be, I think, an urge for people to go and grab their lunch and go. You pay too much to be here. If you enjoyed this conversation, we hope you come back. And that conversation about healthcare efficiency is the focus of this last hour, and we hope you can join us for that.
Folks, thank you. I'm honored that you spent time with me. Thank you for coming.